Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor, a founder of Coaches Club, author at philplisky.com, and a performance systems consultant in professional sports. Being a physical therapist and athletic trainer and strength and conditioning specialist, we like to come at this from multiple different angles. We want to explore the latest research, but more importantly, apply it immediately in our practice. We want this to be practical for you. Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. I'm looking forward to our topic today, open kinetic chain strengthening after ACL reconstruction. We're going to go into that debate. We're going to hit it hard with one of the experts. I'm excited to be joined by Dr. Lynn Snyder-Mackler, who has over 45 years of experience treating athletes with traumatic knee injuries and really has conducted groundbreaking research to improve our practice. It is so exciting for me because we all have mentors. We all have people that we look to. And a mentor doesn't have to be right in your local area. You can read their research. You can hear them present at different scientific communities. And that has been the case for me with Lynn. So welcome to the podcast, Lynn.
Thanks a lot. I'm happy to be here. One of my
Fantastic.
favorite topics.
It's fun. Mine too. It's probably one of the topics I get the most questions on. So it's great to be able to talk about this with someone with not only your expertise, but the breadth and depth of your expertise is going to be great here. Can you tell us a little bit about what initially attracted you to looking at quad strengthening and that passion, how that's evolved over time?
Sure. It's a very easy answer. So you already alluded to the fact that I've got some years under my belt, right? Um, Back in the 80s, ACL reconstruction was an open surgery. So was meniscectomy, right? So an open, and generally they were total or subtotal meniscectomies. And patients would be overnight in the hospital for the meniscectomy several days after an ACL. Um,
As a
and
matter of fact, my ACL reconstruction, when I had it back in the 90s, I was in the hospital for 2 or 3 days. Can you
yeah,
believe that? It's crazy.
so pre-DRG. The audience probably doesn't know what that is either. Um, but what happened was, as a young clinician, I would see the patients pre-op, right, because they were in the hospital, and then they'd go to surgery, and then I'd see them after surgery back in the PT gym, and they forgot how to use their quads. Like, complete is what it felt like to me.
Right.
And also it's what it felt like to them. That's how they described it. I'd ask them to try and do a straight leg raise, and, often they'd flex the knee.
Mhm.
Like, it just complete dissociation between the brain and the quad. And that so the I mean, I basically built a career out of this question as a young clinician is, why did the quad stop working after surgery? And it's actually not just surgery, it's intra-articular knee injury or surgery.
It's
OA.
really anything, yeah. I mean, it can
OA,
be.
I mean, it has to be an intra-articular. So you don't
Yeah.
see it, for example, you don't see it with an MCL, right? It's not isolated MCL,
Right.
extra-articular. Has to be intra-articular. So the patellofemoral joint, sometimes you see it, but that's mostly related to the fact that the entire extensor mechanism is fouled up, right? It's a direct attack on the sensor mechanism. But anyway, this the this it really is this very symbiotic relationship, right, between the quads and intra-articular knee injury. So
So that's how you got started in it, like, I love it, and
yeah,
I love people to hear that this question, having that, question early on in your career. Mine was always about, athletes, why are they getting injured? It
mhm,
seems like athletes that have poor balance tend to get more injured more frequently than others. So I love to hear that, and I want everyone to hear that, like, what is that question that's burning for you? I think that's awesome. But why is it so what, they can't do a straight leg raise? What's the big deal? Why is it important to, discuss this? I mean, we know we should get some quad strength back and things like that, but is it beyond that?
It is very beyond that. Quads are involved in all kinds of, predictions of poor recovery, right? They are, um, people who have it's the number one predictor actually of success after most knee surgeries.
That's a strong statement.
It's the truth. So, number
I promise, I
it's the
swear.
truth. So, it's the look at check you check the literature. That's where you are. So, if you I mean, I would say with ACL reconstruction, you start if you are at week 2, you've controlled the effusion, they have full extension and pretty good flexion and a good quad activation with a superior patellar glide, you're home, right?
Yeah.
You've already won. But if you aren't there, it can be a long, slow slog. So it also is a predictor of the development of knee OA, quad weakness.
Both
So
in the short
both the
term, it's a
short term and the
functional
long term.
predictor, and then
Yeah.
in the long
And
term, it
it's an independent predictor of re-injury after ACL reconstruction. So,
yeah, so we cannot diminish. I've gone through the cycle, and I
yeah,
know you have too, of, back in the day, it
yeah,
used to actually be all open kinetic chain type of
yeah.
strengthening, and on our isokinetics machines, we had the anti-shear device, the anti-tibial anterior translation anti-shear device, right? And then it kinda went to functional training, more closed kinetic chain training and things like that, and that was the big rage, for a long time, but we're at a point now, where I think there's just so much confusion. It feels like people have gone to one side or the other, like, we're just gonna do functional training only, and, open kinetic chain strengthening is unsafe, it's painful, it's inappropriate, it's gonna cause graft problems. W
So
you
can I
know
just say no, 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 and no?
Yeah, absolutely,
That
yeah.
but
So,
but yeah, I
what would
also
you say to clinicians about that? Like, how would you describe that? Like, what does the research say here?
I don't buy that premise, but I'll give it to you for right now. But,
Well,
um, I mean, I
when you
think
say you
what we're
don't buy
seeing
it,
is what
it's
we're
so
seeing is a
much out
lot
there.
more acceptant, a lot more it's growing
It is growing for
significantly. I
sure.
mean, I would speak in a like an international soccer meeting, and I just was at the same one that I've been at every year for 30 years, and there'd be I talk about open kinetic chain 20 years ago, let's say, and everybody would be up in arms over it, right? And now it is actually like the newest ISICOS guidelines that just were published.
Mhm.
Totally in favor, right? The evidence is completely in favor. And the part that's hard to get at is, are you really happy when your patients have like 50% quad strength at 6 months or
Right.
60%? I mean, if the closed chain stuff works for you, here's the problem though, and you're gonna ask me or talk to me, we were gonna talk about this today. They don't measure. So if you're not measuring quad strength, and that doesn't mean somebody on a leg press, I mean
Right.
actually isolated quads, you don't know if they're getting stronger, right?
And that's exactly it. I think we're at a and that's just gonna be a whole 'nother podcast,
Yeah,
so I'm looking forward to that.
yeah.
I mean, we're at a place where we're not measuring, and so we don't know. They seem to be doing well functionally, but the research tells us a different story, doesn't it?
They're not they may look to your eye as though they are, but they're not.
Mhm.
Like, if we put them in the lab, you see all kinds of adaptations. When someone I mean, you can't really go foot over foot upstairs until you have quad strength that's at least 60%, probably more. And then coming down, you also need that or a little bit more. And coming down, you need a lot more flexion.
Right.
There's a lot so there are all these compensations that people make. And again, with the closed chain part of the gait cycle, you can shift the control away from the knee to the ankle and the hip to get the knee flexion because we have biarticular muscles.
Right.
So I mean, 3 of the 4 hamstrings are biarticular, right? The gastroc, the 2 medial and lateral heads. So you can get a lot, even the soleus. When the foot's on the ground, the soleus acts to advance the tibia during walking.
Yes. Well, and that's I
So,
think
I
I
mean,
think we've gotta recognize
control the advancement of the tibia.
the body prioritizes gait at all costs, right? Like, it prioritizes ambulation no matter what compensations are going to
Yeah.
occur, it is going to wanna get it done, and, whether that's after a stroke or whether that's
Mhm.
after an interarticular injury, that prioritization
That's correct.
is great, is awesome because it keeps us going, but with that said, I think the research tells us a different story as to whether it's good or not.
So you're a strength and conditioning coach as well. I mean, we all know that if you want to test a muscle, how much time do we spend in the shoulders saying what's the the position that best isolates each of the rotator cuff muscles, right? If you want to test the strength of a muscle, you need to basically it's harder in the shoulder. In the knee, it's really easy. The quad extends the knee, the quads, right? So set it up and test it and see if they're getting stronger. The whole ideology of this fear of open chain exercise sort of came after the over the isokinetic era, right? Where the it was not only that part, but the isokinetics got blamed for loosening of grafts.
Mm.
And if you look at the orthopedic literature of that time, it's what we saw at 10 years later is that their graft placement was vertical. And so the only way you could get extensor back is to stretch, right?
The
Was
graft
not
half.
the quads. It was not open chain quads. Could have been it was just they're either gonna have a slight flexion contraction and be unhappy, or they're gonna be a little loose. You make the choice. It's gonna be one or the other.
So then they changed graft placement,
Sure. Yeah. Made it
and
more
that
anatomic.
caused a more stable knee, but the folklore, if you will, and I that's maybe that's
No,
not
no, we
maybe
got
that's
blamed
too
for it.
strong of a
I mean,
word.
actually, we got blamed for it
Yeah.
for a long and that resulted in a lot of, I don't mean to be so strident, but I mean, I'm married to an orthopedic surgeon, so we'll start there. Um, I I think the upshot was that, it was easy to blame the rehab and to
Mhm.
blame these newfangled machines, right? So, um, so what we need to do is go back and look at that and then look at what happened as a consequence. Not only, poo-pooing or blaming open kinetic chain exercise, but having us get rid of these devices,
Mhm.
electromechanical dynamometers that are the best way to isolate all different muscles to be able to get good, reliable strength data. So it was a double whammy
Well,
for
and we're
us.
still feeling the effects of that. I mean,
We are.
I'm from Evansville, Indiana, and, we have I mean, we're pretty popular. We're not in the middle of
Yeah.
nowhere, but we're a pretty big city in the Midwest,
Yep.
and it used to be that there were multiple places that had isokinetic testing, equipment, and I just heard there's basically 2 now in town, and I just found out because I was referring
Yeah.
one of my patients 'cause in my practice, I don't
Yeah.
have one, so I just simply refer them
Yeah.
out, right?
Yeah.
And I'm
It's
good with
testing.
that,
Yep.
right? I need the data, but I found that one of the 2 places that I refer no longer, has it. I'm like, "They just got rid of it." I'm like, "You've got to be kidding me." And that's why I say this is somewhat still pervasive, and as I go around the country on clinical site visits and things like that, and the questions I get, this is there. So, let's talk about the research. Let's hit the research head on with this concept that it causes laxity or that it causes strain. Open kinetic chain causes
All right.
laxity or causes strain.
All right. All exercise causes strain. All extension causes strain. Back in the 80s and 90s, the University of Vermont had their model, which was to take a strain gauge and put it on the anterior medial bundle of the ACL. They would do this in the OR, have somebody who, for example, had was having a meniscectomy, right? So they would be, you know, have them awake and then put the strain gauge on and then have them do different things. Straight leg raises, knee extension with a 30K boot, um, any squat with and without a support cord. They even brought a stairmaster into the OR at one point. That one was highly variable because you know how people when people are on stairmasters, they all have these different weird ways of doing it. So some was
It's like
no
watching
strain,
gate
some
at
was
an
like
airport.
the highest straight exactly ever. But their data have often been used as a support for this. So let me get to the first premise. Absence of strain is not the goal.
Right.
Collagenous tissues, too much strain, they rupture, too little strain, they resorb. Okay, so it's got to be somewhere. No, zero strain is not the goal. Absolutely not. So most of the things, including a Lockman, right?
Right. That
Were
they do
are the
intraoperatively.
highest is
Yeah.
around 4% in all those tests that they did, right? All of them, and open chain exercise with a boot, with a 30K boot, and closed chain squats with a sport cord were almost identical, 3.8, something like that. So basically, roughly around 4, right? No difference. So somehow that got sort of somehow they like glommed onto the extension part, but open chain de-extension, but didn't we're like all over the keep doing the closed chain.
So
4%
you're
better.
actually citing the same research that is cited to in the opposing view of open kinetic chain that it is not good for the ACL. You're citing the same research that they did,
Yes,
just
but those researchers didn't that was not their thesis, that you don't do open chain. That was so, Bruce Bainin at University of Vermont, Braden Fleming, who's now at Brown, and Bob Johnson, orthopedic surgeon. That was not their conclusion, right? It's just, it was sort of used so I don't even know how it got out of control, but it got out of control.
what research is there to say, I mean, let's take the opposing view. In the last 15 years, you are in the research daily. In the last 15 years, what research is out there to say that open kinetic chain would result in either increased laxity, too much strain, or rupture in the last 15 years? Is there any
0.
that you're aware of?
0. So, I mean, no one's ever proven that at all or shown it.
So what's the difference then? What's the difference? Why does I think the argument
If you're
is
gonna ask me why do these myths persist? We could do a myth buster episode, right? Right? I mean, they just do. They carry on and
well,
what
I think part of it is if you like, risk benefit ratio, if someone's looking at that and they're first of all making a false premise that it is increased strain.
Yep.
Now, even if we acknowledge that's a false premise, they say, well, but I can get the same strengthening in a closed chain
And
with
I'm
that.
gonna say, "Prove it to me." If
Yeah.
you can, I don't think anybody should change their rehab, but I'll bet you they're not measuring. Right?
That's an interesting way to look at it because I think that's and again we'll do a whole episode on measurement because
Yeah.
I can't emphasize
Mhm.
how important that is. But the idea that we it's because we don't know. I say this a lot. I really don't care what method you use in rehabilitation, but your outcomes and your measurements
Right.
need to be pointing in what the research says are the important outcomes and measurements, right? And so I don't care if you have a patient stand on their head in the corner and that restores their quad strength, so be it. But I think that's a great
So so
perspective.
so there's a lot of, like, sexy topic right now, right, is the brain, right? How the brain is affected. If you Dusty Grooms, who's, at Ohio University, if you look at his work and the work of his students, um, one of the things, another important quad thing. So when a couple years ago, I think it was 2 years ago, there was a paper, one of his students was the first author, but they were looking at this changing of mapping in the brain that happens that when the quad again, I told you, it's like this confusion in the brain, and so it goes to other centers to help control this, extension, and what he found was that those patients who had recovered quad strength early never developed those changes.
Interesting.
Interesting is right. Yeah, it is. So, and again, we have solutions for these problems, right? We know what to do. Um, I mean, my entire career, and certainly my career at 35 years at Delaware, and still in our clinic, patients are referred for exactly what you do for strength testing, most often from their surgeons, and they get this like, look, 6 months. Oh, your knee looks good. Send them in, and they're horrible,
Right.
right? Horrible. 40%, 50%, 60%. You would let somebody go back to play with that? No, but no one measured.
But yeah, worse yet, we don't know, and that's exactly what I found. My practice is largely now made up besides, baseball players.
Yeah.
The second half of my practice are people who have been discharged from rehabilitation at 6 months, and they don't feel ready. So I have local surgeons say, "Hey, you need to go see Phil. They'll get
No,
you ready."
perfect.
But it's a blast. I love it, but it breaks my heart when I ask the questions of, "Were you strength tested? Are you in the gym doing, knee extensions?" Right? I mean, like, single leg knee extensions. "Are you in the gym?" "Oh, no, 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 we're not doing that. I'm doing leg press. I do single leg press." And then we go through the
That could be all
process.
glutes, right?
Yeah.
So, um, we tell our patients who've had these major interarticular knee injuries that they should be doing quad strengthening exercises for the rest of their lives, right?
Yeah.
Because that symbiosis doesn't go away, right? That ligament is not is th that ligament was replaced by an avascular, aneural graft material, a tendon, right? So, and we know the prediction of weak quads to OA, and they're
Mhm.
already at risk for OA from the traumatic knee injury, so yeah.
Tell me about that. Tell me about that relationship between knee OA and quad strength.
Well, you know what happens, I mean, you're pa every all of you out here have treated patients who have ACLs. You watch them walk
Mhm.
after their, after their injury or surgery, and they walk with a, quasi-static gait, being getting into the biomechanics part using physics terms, but
Right.
doesn't matter. Um, they They land with a pretty much of a flat foot, the knee slightly bent during when they land, and then they flex a little more during stance, but nowhere near the 20 to 25 degrees that you and I would have when we were walking. Um, when you think about that, it does provide stability, but it really truncates their range of motion, and it also, um, there is a higher ground reaction force on that because 'cause they're just like, bang, and what they don't do the other thing they don't do is they don't push off, right, in terminal stance. They just kinda lift off, and the more I mean, that's my doctoral dissertation, which was in 1989, 90. There's a paper in JBJS. We showed that the weaker their quads were, the more stiff their gait was, right? And And that's held true through, papers in the '90s, papers in the we keep showing it in different populations. But, it's important to get to that, and you can't really break that pattern if their quads aren't strong enough.
Right.
So, here we go. There's a hole in my bucket. That song, remember? We're in that
Right.
craziness where,
Yeah.
um but let me just hit one more thing about the myth part. As I said, absence of strain is not the goal. Some research in the last decade, different methodology, but still similar, like biplanar fluoroscopy, right? So 2 fluoroscopes, and, for in the last century, the end of the last century, there you had ability of Juan Lee at Harvard and his group and Scott Tashman. You would have to be, pretty static,
Mhm.
so you could do squats, for
Right.
example, and look at what happens, and it actually so you're looking actually at the bones that are brought in from a CAT scan, the patient's own bone morphology, and then it's superimposed on in this, this fluoroscope these dynamic fluoroscopic images, and you can see actually how literally strained, like, you can calculate the strain. So now you can do it the volumes are bigger, so people can walk, like, full strides. They went from the squat to a treadmill, a little bit bigger, right? And now they can do overground walking. So Lou DeFreight, so professor, at Duke, who came out of Bonley's lab, the first person that I mentioned at Harvard, and he's shown in multiple papers, but to the 2 that I cite the most often, I think I put one of them in the bibliography, is that during walking, there are 2 peaks of strain, one during stance, one during swing, that are like 11 to 15%. So take us back to what was measured, a different methodology, right? But as 4%. So you're letting them walk.
I mean, even if we're 4 times wrong, like 4
Yeah,
a
right,
magnitude of
yeah,
4 wrong, it's at least the same.
and it's the same for 1 step,
Right.
right? Multiply that strain over time.
Right.
But again, let's flip back to the absence of strain is not the goal, and let's get back to collagenous tissue. The ACLs are replaced with tendons. Tendon and ligament are cousins, essentially,
Right.
in terms, but but tendons are more elastic, so that you want them to become they they do tendons don't heal and ligaments don't heal unless you're giving them the strains that are in line, right?
Right.
Telling them, "This is the way scar tissue, line up here along these lines of stress," right? Otherwise, it turns to like the beginning after Achilles tendon rupture. I think everybody here has seen them. If you're very conservative and you're not putting strains across that repair, they end up with a big ball of scar.
Right.
And that tendon is way bigger than the tendon on the other side, but it's not organized and it's not strong, right? So you have to apply strains in, right, like this. So we need that for the new collagenous tissue to heal, to and to line up in a way that it's supposed to do the job it's supposed to do.
Now let's talk about that because it makes me, I think I don't know that anybody, I've not seen it in the literature and I've never heard a case of it that someone was doing open kinetic knee strengthening and the ACL tore. I've not
No,
heard of that, right? I've,
no,
I've never
no,
heard of that.
but
So
Phil,
so but
also
the argument is that it stretches and that again, we know the strain probably isn't there, but do we have any idea that it does or doesn't?
you can't really stretch without a strain.
Right.
So,
That well, it's already stretching from other activities if it is indeed stretching.
yeah, potentially. Yes. And there's tons of data on what happens over time with the anterior for is the easiest one to measure, right? Anterior tibial translation. But it's uh, let's talk about when they are talking about this being dangerous, right? Okay. How strong is the graft when you put it in?
It's probably its weakest.
No.
No?
It is the
12
strongest
weeks?
it will
12
be ever.
weeks, yeah.
No, at the
No, 12 weeks is the weakest, right?
yeah, so that's based on Bill Clancy's work in monkeys in the 1980s,
Yeah.
right? So we probably could revisit that.
We revisit it, sure.
Yeah. But, and they were casted. It was a model that doesn't
exist
resemble
anymore.
what we do now.
Right.
But that's so this is what happens if they're right when they're immobilized. That's a good right? They should get weaker. We should be able to and I think contemporary ACL rehab does um lessen that curve. But why people are going, "Oh, that's the strongest the day it's put in."
Right.
It's this big gigantic tendon compared to this little ACL. The strengths of hamstring, quad, and quad tendon and bone patellar tendon bone are way more than the native ACL. So that's the time you have fixation. That the concern early is fixation failure.
Right.
Yeah, I don't really see it. You seen fixation failure
No,
early?
I've not at all. I have more concern about harvest site
Yes.
failure than I have about fixation failure,
Okay,
right?
so
Because essentially, if we're taking a bone, patellar tendon bone, we've created a fracture in the patella, we've created a fracture in the tibia, right? Because I mean, the definition of a fracture is
yeah,
that we've disrupted that trabecular structure, and that is disrupted, right? And so you probably should have more concern about gait at that walking at that time than you should about open kinetic chain,
I don't know. So we have to look at what's the strain on the patellar tendon during walking. I just
yeah,
told you that the strain was on the ACL.
right?
But my colleague Karin Silbernagel at Delaware, we've we've been collaborating over the last bunch of years. Now Ito, a former PhD student who's now at the University of Wisconsin, his dissertation. I think I put one of his papers from Journal of Orthopedic Research. When you take that central third of the patellar tendon, harvest it. Um, so ostensibly the lateral and medial parts of the tendon have not been touched.
Right.
But when we look at them a month out, the tendon itself is twice the cross sectional area that it was, or then its other side. Okay. So what is all that stuff? It's
Mhm.
ground substance. It's waiting for some
Stress.
right?
Yeah.
Mechanotransduction, some mechanical signal to say, line up like this, right? And that sickness of the all three parts of the tendon get better over time, but not in everybody. So we have people if they're not getting a we have people we have ultrasounds from people who just came in and were looking at ultrasounding patellar tendons after ACL, and their central third is still a big mishmash of unhealing, right?
Mhm.
So they didn't get the appropriate strain. And we could learn a lot from the tendon people because the m- pain modified strength training, not pain free, right?
So go
So
into that.
they use the pain modifying model of if your pain is 5 out of 10 or lower, you keep going. If it's more than that, you have to modify your rehab. But it's not again, absence of strain isn't the goal, and absence of pain at the site of a tendon injury is not the goal.
So if we look at that, let's apply that. Can we take a peek into your first 2, maybe 4 weeks of ACL reconstruction rehab? Let's assume patellar tendon bone graft. Walk us through what that looks like and we'll isolate to the open kinetic chain perspective, right?
Sure, it's
Let's
fine,
just
but
stay there for right now.
if you can, anybody's welcome to go to our udel.edu PT clinic website, and if at some point I could share this, but we have there's a tab that says for rehabilitation professionals, and it's practice guidelines in there. There's also information about residencies, etc. But
Right.
um, and it's organized. The tabs are by joint.
Mhm.
Okay, um, our our we call them practice guidelines rather than protocols, right? Is because they're a recipe.
Right.
So when I'm talking about what we do, I say, do you need to change what you do? If here's what we do. Here are the milestones that we're looking for at these time frames. If you're hitting those milestones at those time frames, go girl, keep doing what you're doing.
Right.
But if you're not, here's a recipe for it, right? And my recipe, I always talk about, like, my grandmother's chocolate cake recipe might be different from yours. They're all chocolate cake. As long as you get chocolate cake, it's fine. But if you are not getting these results, so what are we start pre-op. We do a pretty extensive pre-op if we can,
Mhm.
and with most of our patients we can. Um, that involves at the tail end of it neuromuscular training in addition to strength training, right? So we've been doing strength training all along. There's really no reason to not do strength training. And um, isokinetic or open chain exercise puts less joint compression. A lot of work in weight bearing is
Mhm.
generally associated with more fusion, right?
Mhm.
So keep them off. Don't
Now
keep pounding that joint.
is that a that's I totally agree with that statement. Is that something that we see in the literature, or is that your experience?
Oh, I think that's why the restrictions on weight bearing after significant interarticular injury. Like, you can't just, not every, but probably as we get better imaging, every ACL has bone bruising, right?
Mhm. Right.
So,
Yeah, one on the
and
tibia, one on the
and
femur,
that's
right
one of
there.
the
Yeah.
things that hurt.
Yeah.
So again, why I'm not a big fan of, like, a lot of close chain exercise early after ACL injury.
Mhm.
And then the surgery is another injury.
For sure.
It's a big deal. Little now they're in little holes, but they're still the same big surgery, right?
Right.
Drilling holes in the bones. What we do is, even if we see them just once, is we teach them a towel stretch into extension. So heel on a sitting up, long sitting, heel on a towel, and doing pulling, put a heel on it, pull using a towel or something to pull a strap to pull their knee into full extension.
Full
And then we
hyperextension. I'm
yeah.
using the word
Well,
hyperextension
full
because
extension is full extension,
I know exactly,
right?
but
It's not zero.
I think
It's
people
not zero.
excuse it. Yeah, and that's
Yeah,
my passion area is people
yeah,
excuse they don't recognize that the human body has, in general, in the knee, 5 to 10 degrees of
yeah. So
hyperextension.
use your other knee.
Yeah.
Um, if your other knee is 0, then 0, but
Right.
full extension is not 0. So they do that pre-op, and they start the day of surgery doing the same things. And the second is a wall slide supine. They're in supine with the wall up. They're
Mhm.
put up on
Yeah,
the
the kind of
wall.
90-90 position, you're going
Yeah,
down, yep.
you could try and get well, yeah, they might get there the
Right.
first time. But you're the active there's a couple reasons. That puts them in a very aggressive, um, elevated position, which is
Mhm.
good for the effusion, and they're using their muscles to do that. Muscle pumping is also a great way to
Right.
reduce effusion. So we start with that. They start doing it. Then they come in and sorry, and we do the same thing. We have them do those same things with more supervision. We start open chain exercise that first day. We do open chain exercise, which is a straight leg raise or long arc quads with no weight, right?
Do you
No,
have a particular degree of long arc quad that
doesn't
you
matter. Just we have them go through their whole range, but if you're really worried, then have them start with their foot on a chair so they're at like 60.
Yeah, but there really is no so now let's talk about how you deal with pain in
Remember,
that.
strain is open chain.
Strain is good, right?
Strain,
The
right?
and this is
Optimal strain is what we're looking for.
so let's talk about how, you mentioned earlier, like, okay, learning from the tendon research and things like that. Let's say I'm starting, I figure out what's a good range, whether that's, some people I find actually 90 to 60 is much more comfortable than 30 to 0, right? And it depends. I mean, it
I I
really,
I actually think the literature shows that if you actually look like one of our former I have a long-term collaboration, the Delaware Oslo cohort, and one of our first PhD students on the Oslo side, Ingrid Eitzen, for part
yeah.
of her dissertation, looked at, the kinetic curves. And the terminal part of that, they were much weaker
Yeah.
than right? So that getting it all the way through. So it was, it's really important, and I think it's really important to get them all the way through the arc. So
So what is your pain? So let's do a little patient role
okay,
play
okay,
here.
no,
So
stop,
I'm
stop.
doing a longer quad.
Just
Go
give me
ahead.
1 second. The bump when do your bone patellar tendon bone patients start complaining of pain? When they did that tendon harvest, most of those superficial nerves are cut.
Mhm,
They're not very far, but they take a while. So you usually they're usually fine early on, and then, as you get to 6 weeks, 8 weeks, 12 weeks, they start getting this patellar tendon pain. And at that point, you're talking about the graft site.
mhm,
And that is we use the tendon pain modifying model for the tendon because in that case, if the tendon hurt that graft site hurts, you need to help that tendon reorganize. And so I have to send you guys to the tendon literature to look at this, but you are rehabbing a sick tendon. You are not rehabbing a ligament at that point.
well, and I think
The
that
graft site.
yeah, I think that to me actually makes one of the things that really bothers me in rehabilitation is in a healthy tendon,
Yep.
when we're doing painful activities, we are changing neuromuscular control. The literature is replete on that,
Mhm.
that if you're doing painful activities with a healthy tendon, healthy, everything's healthy and it's painful, that's just wrong, right?
Yeah.
And so but with this said, though, we do know again Achilles, patellar tendon,
Mhm.
lateral elbow, all those things. There is this importance of loading the tendon, and that maybe doesn't have to be may be painful, right? And
Well,
so
right, right. It may be painful, and it really, actually, if we were dosing, you probably want it to be a little,
right. So,
right?
but
But
that to me makes the case for the open kinetic chain more than the closed kinetic chain, because the open kinetic chain is not neuromuscularly, in my opinion, the same as what the body is trying to do when it is squatting or engaged or in a lunge or whatever. If I have pain during that activity, I'm going to compensate with other
you are.
muscles.
You're gonna
And
unweight it. You're
yeah,
gonna shift control to the proximal and distal joints.
yeah,
I mean, there's
absolutely. And
lots
and
of
and
ways.
and and so that tells me actually more that I'm much better off, because when I'm doing an isolated, longer
Yeah,
quad, shorter quad, when that's isolated, there isn't really anything that can compensate,
no,
for it. So I'm not damaging the neuromuscular control, if you will, or causing compensation in the neuromuscular system. And I'm getting the isolated tension and strain and strength that I need.
sure. I mean, you you cannot expect normal movement patterns when the 3 basics and the young therapists get bored, right, with this. They ask me all these questions about, "What about BFR? What about" we did this long electrical stimulation. I think I told you this long electrical stimulation session at CSM this past February, and after all of this stuff, the first question we got was, "Do you think we should add dry needling to that?" And I was like, I wanted to say, "Are you in this room?" So they handed me the mic, and I just said, "No."
No.
That was my answer.
Can
Like,
can we stop can we stop for a second?
"Yeah, can we please?" But what we really wanna say is, if you get those full extension, good flexion, right? You're moving toward flexion that's symmetrical. That can take a while. Um, and then reducing effusion. You never want the effusion to go up,
Right.
right? So they could have like a 3 plus effusion. You should all learn the sweep test for testing the degree of effusion. And we don't if someone has a 2 plus effusion, we do not progress their weight bearing exercise, right? I mean,
Absolutely.
so I mean, you one of the things that and I threaten so young kids, teenagers, they're, "Oh, wow, I'm off my crutches." And they come in with going from a 1 plus or a trace to a 2 plus. And I say, "If you don't watch what you're doing, you come in the next time and it's this swollen, you're going back on crutches,"
Yeah.
which they don't want. But too much weight bearing is is often the problem. So, um, back to the first week, we have goals for that first week of where we milestones that we want them to hit. Um, and then we start uh, open chain quad exercises the second or third day after surgery. And we also do a pretty aggressive neuromuscular electrical stimulation protocol that is in open chain. Um, And in order to dose that appropriately, we do an MVC
Oh,
ev
that's gonna be we're so
every
we're
single
gonna have to unpack that
yeah,
in the next episode
yeah,
because that is I think if we can go away from this episode saying, "All right, there's no reason that open kinetic chain is not safe," and as a matter of fact, it's not only not safe, it's safe, it is necessary for strain, we have to get that. Now the how of that, the how of strength testing and the how of neuromuscular re-ed we're gonna have to save for the next episode. So with that said, this is you've had the world stage for 45 years, but I want to say, like, from this concept, regarding this concept, what are the three things that, for this audience that's hearing you today, what are the three things that you're like, man, this is what you need to do in clinical practice, these three things regarding open kinetic chain?
let me give you, again, send you to our clinical practice guidelines, which are extensive and well thought out on the ACLs, the ACL recent adaptation, and it will take you through the progress. But range of motion, decrease of fusion, quad strengthening are your big 3, right?
And one thing we didn't touch on, we know I just go through on the literature on what a fusion does to our neuromuscular control, our quad, all that kind of stuff. Just recap that really
Yeah,
quickly here because I think it's missed a lot.
a fusion is a big player in quad inhibition or a failure of voluntary activation, which is what I talked about, like, way back when you asked me what was the impetus for doing this was, like, that my patient forgot how to use his quad,
Right.
right? So, um, fusion is a player, pain is a player, right? But it's also that intra-articular knee injury is the player. It messes up it's scientific term, right? It messes up the communication. So,
That's awesome.
but
That's awesome.
anyway, if you go to you'll see all of the, all of our practice guidelines are free, right? And it will say when each has been updated most recently. So you have, and we try and publish papers to go along with it that helps to inform our how we moved from our, you know, in the 90 our late 90s uh, protocols to the 210s to now, right? Um, but it's pretty specific, and then we have spots on there where we talk about what's different for each graft type.
Which
How
is
do you have
important.
to
Sure.
manage your rehab for each graft type? And that's not just the graft site healing, it's things like the hamstrings, for example. You take the hamstrings, that hamstring will still fire when you try and flex your knee. It's still connected, but it's gonna pull up your leg, right? So we don't really wanna be strengthening those for the that's the one you wanna really avoid for a while because
Right.
you'd like it to not end up feeling like a hamstring pull for the rest of their lives. So anyway, those are the kinds of things, very practical. The progression for open chain is in there. It's just a table. It's very easy to follow, and you can see it's not like throwing weights on people right away, but this is what we're doing, and we move very quickly to PREs, right?
Right.
When the joint is you wanna get that joint calm as quickly as possible. And, oh, active muscle activation is a good way to pump that out, right? So range of motion, a fusion, quad strength, those are like the big 3. And
Yeah,
I don't expect them
can't
to have
miss those.
normal gait patterns till they have the base that would support that.
Absolutely. Back to the neurological system in that, right? Like, why are we so aggressive to get them off crutches when they don't have if they don't have the foundation, we know they have to compensate to get that. Why that's not the goal. Our number one goal should be get them the foundation so
Yeah,
that they can get off crutches
yeah,
and that they can
and
do
like
these
I
other
said,
things.
that part's boring,
Yeah.
right? But it's pretty rote, but if you do it well, your patients are gonna win.
I say this all the time, the fundamentals win every time. That's why professional baseball players still hit off the tee. It's something they did when they were 6 years old, yet it grooves their swing in the right way. They can feel the thing, and that's professional baseball players who have taken tens of thousands of pitches, live, hardest thing that you could do, yet, they're still hitting off the tee. I think the same, application should be a great learning point. So with that said, like, as we finish up here, can we impart some words of wisdom to our audience of these 45 years plus in practice? If you could go back to when you started,
Mhm.
what advice would you give yourself?
Be curious. My first boss, Ruben Selesnik, who was the chief of physical therapy at Yale New Haven Hospital, so this department had, you know, continuing education courses for the staff pretty much constantly.
Mhm.
And he said the half-life of a PT education is 5 years. If you don't keep if you don't keep up, right, you're losing. So, I would say that was one of the big. I'm not sure it's exactly that percentage, but it's a
But it's the concept really
yeah,
applies. Like,
keep
you don't
learning.
lose your knowledge, but you are losing compared to what's going forward around
You're
you.
not on the train, right?
Yeah.
You're not. So and it's so much easier now, right, to just go on PubMed and look up, just be really careful. Stick to reliable sources, like, don't do Reddit for this, right?
Oh god.
Please. Do you know, there's lots of aggregates of real literature,
Right,
and
absolutely. JOSPT
and
does a great job, I think, of that,
and then but we also have to be careful of the proliferation of systematic reviews and meta-analyses, because they're only as good as the literature the worst piece of literature they use.
right.
And they come up with these conclusions, and they all say weak evidence, right? Yet not just in our section, but in lots of others. Um, you have to be really careful. They're not the top of the evidence heap if the evidence that they're including
It has
is
the bottom
level
in it.
5 or
Yeah,
something, right? I mean, it just isn't.
absolutely.
That's how high it is. It's somebody's
Right.
opinion. So, be really careful, because those get journals like SRs and MIs, because they get hits, right? They get citations, but they aren't, as I said, they're
It
only
depends.
good.
It's just like one of the things we have to look at as systematic reviews
Mm,
in meta-analyses is just like a randomized controlled trial, it's really only as good as the methods and the people doing it, make it and what their bias is, right? And so I think
yeah.
that's an important thing.
So
Well,
just be careful
fantastic.
with
This
that,
is
and try and look at the primary literature if you can, because it's
Oh,
don't
absolutely.
be afraid to go back. Like, there's revisiting this or reinventing the wheel. Somebody to repeat the studies that Tony DeLito and I did in the, 80s, when the results were definitive,
Right.
right? Um, yeah, we know neuromuscular electrostimulation works. We'll get to that in the
Well,
next.
that's and we do have another, episode planned that we're gonna talk about electrical stimulation and strength testing after ACL reconstruction, so I'm looking forward to that. In the meantime, how can people connect with you?
My you go on the UDEL website, and I use my UDEL email, so that's probably the easiest way. Twitter, you can do that if you want. I spend a little bit less time on that these days. Um, but yeah, it's pretty easy to get in touch with me.
Oh, that's awesome. I can't thank you enough. It has been an absolute pleasure. I'm looking forward to even going further in this concept in our next episode. But in the meantime, if you'd like to connect with me, you can find more information about what I'm up to, what I'm learning, what I'm working on at philplisky.com. So until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcast@medbridge.com. See you next time.